Hey everyone, I'm Sebastian. I'm going to cover degenerative disc disease today, as well as some parts that I think you're really going to want to know about. For all you watching on YouTube, you can see the slide right here. We have, in this video, we're going to cover what current research says, how it happens, treatments that work, prevention, and also for the people on YouTube, there's going to be two of my favorite exercises. It's not going to be in the podcast. There's a podcast version of this. It's called Restoring Human Movement. If you're listening on that, you can always go over into YouTube, just search in performance place sports care, and you'll search degenerative disc disease, and you'll find it here. So I'm going to do my best to entertain both audiences today, but we're going to go through some really great information that's going to give you some insight about what's going on with it. Now, degenerative disc disease, as you see by the picture here, some of you do, is you see all the stars all over this person's back. And so a lot of you may experience tightness into the side of the lower back, into what you might call the QL muscle. You might also feel it into the area of the kind of the bony parts of the spine, right along the middle. It may go all the way up into like the bra line region, down into the SI joint region, down to the sacrum, tailbone, and so on. A lot of you will actually experience correlated hamstring tightness, sit bone tightness, piriformis muscle, gluteal tightness right around the crest of the hip where her hands are in this picture. Like if you were mad, you'd put your fingers there, or your thumb would land there. Hip flexor tightness, and so on. And so the feeling of tightness associated with this, whether it be restricted of movement or not, is a completely different story, but it's super common. So we're going to go over, again, what current research says, how this happens, how degenerative disc disease happens, treatments that work, prevention, and two of my favorite exercises. So the first thing I pulled, this is a study from 2019, and I just took a screenshot of a certain section. Down to the second line that says there's no single definition was used in the majority of publications, and most frequently the term was used without any definition provided, which was in 30%. In other cases, degenerative disc disease specifically included radiculopathy or myelopathy. Radiculopathy is a pinched nerve. Myelopathy is cord compression in 14%, or only back or neck pain, which was 5%. So this term was thrown around a lot, and this is over the course of this research article. This is level 4 evidence. It was talking about 402 publications. It's interesting how much is just thrown around, and there's no consistency really about what we're even talking about, whether the research is investigating treatments, who it's specifically in, and so on. Like all this information we get about them, it's kind of haphazard. It says, in conclusion, degenerative disc disease represents an underdeveloped concept with greatly varying definitions documented. Such inconsistencies challenges clear, accurate communication in medical and science, creates confusion and misconceptions amongst clinicians, patients, and others, and hinders the advancement of the related knowledge. Interesting, right? So all the things that Dr. Google says is not necessarily correct. And obviously in this podcast or in this YouTube video, you might say, well, you might be spreading the wrong information too. I'm going to do my best to try to keep things as wishy-washy, but also as concise as I possibly can, because there's different terminology thrown around all the time. Now, the mechanism of injury is usually slow onset. It doesn't happen overnight, although some of you may feel more in when you start to get up or one day after a certain activity. Perhaps you went golfing yesterday and all of a sudden you feel it more today. It's kind of like the day where it peaks, but a lot of people can't really identify when it started. It just started to come on over time. Usually there's no trauma or accident. It's not like you fell golfing. It's just you went golfing. Also, there is adaptation over time, which I'll describe the picture on the left. And there's also a thought that it's hereditary. Hereditary, I think we should touch on that first, is I would question how accurate that is. There's obviously things associated with the body, which is obviously hereditary. It's familial. It runs in family lines. And that happens. Like rheumatoid arthritis is a type of arthritis, which can affect the spine, can affect other joints as well, but it does happen more consistently with hereditary. So, but there's a lot of other factors too. Are you sleeping well? How do you treat your body? What do you eat? I'm sure some of you may have heard of the term epigenetics, or the it's kind of it's like selective gene expression. So although you may have the gene for it, your genes may say you're supposed to have it, or you may have it. It doesn't express in everybody. Like you have it, but your sister doesn't. So with that being said, there's a lot of other variables associated with what's going on. It's not only physical, but also chemical too. How you treat your body, what you put in it, and sleep, stress, and so on. So there's a lot of different factors. But if you look at the picture on the left, here's a couple different phenomena and problems that happen in the spine. And so you see on the left on the top, it's a normal intervertebral disc, they say. The second one down is a quote unquote degenerative disc, where it seems like it's more macerated. There's splitting in the sides and there's less disc space. The third one down is a disc bulge, and then there's a disc herniation, and then a thinning of the disc, which is often said to be correlated with degenerative disc disease. And a lot of times you'll find arthritic formation, which the fifth one down is disc degeneration with osteophyte formation. Osteophyte can be called spurring, like fish lipping. On x-rays, a lot of times you'll find it, or you can just generally call it arthritis, osteoarthritis, and so on. So there's a lot of different words for it, but generally speaking, it's a change that happens between the vertebral bodies in the space of the disc that usually happens over time. It's an adaptation over time. In the next slide, I think this is how I usually explain things to people when we're talking about degenerative disc disease as well as degenerative joint disease, and they wonder why they have arthritis, maybe in one hip and not another, and so on. It's really about how you treat your body over time. Again, some of it can be hereditary, yes, but at the same time, there is something called Wolff's Law. Wolff's Law is something that we learned about in, I think, probably the first year of chiropractic school. I'm sure that physical therapists, medical doctors, osteopaths, physiotherapists, they all should be generally familiar with it. The recommendation for walking or doing weight-bearing exercise, if you are osteoporotic, in regard to building bone density, comes down to allowing the bone to remodel in a favorable way based upon how you treat it over time. With that being said, osteoporosis or bone thinning won't go away overnight. It is a process to remodel the bone in a favorable way. With that, under that same thought process, though, it does not happen overnight. It comes over time as you don't treat your body to a little bit of load. So in the picture on the left, this shows a femur, and this is a compressive load downward. And you can see with this particular picture on the left side of the bone, there's less compressive force than on the right side of the bone. And so you take that bone over time and you take a look at it in the middle, and it shows on the side where more compressive load is, new bone will add there, while on the left side of the bone, new bone or bone will be removed from there. This is called osteoclastic activity. The bone remodels. It's a naturally occurring thing. And what you have at the end of it all is a bone which can tolerate the compressive force that you put upon it. So bone is not a tissue that doesn't change. Bone is a dynamic tissue, meaning it does change. So this slide says Wolff's Law holds that bone will grow and remodel in response to the forces or demands placed upon it. And this says examine the bone on the left. So this makes complete sense to me. And this is a type of the femur here. The thigh bone is something that we would be considerate of when people are want to make sure they don't have get broken femurs when they fall when they get older. So that's why we want to have people generally active throughout their lifetime, is because gravity supplies the compressive load in that case. Now, this picture is one with, it's a man or woman standing, and it shows what we can call good posture, bad posture, so on. Like it doesn't really, let's not focus on the posture associated with it really. The person on the left has quote unquote ideal alignment. And then there's kyphotic, lordotic posture, which is kind of, if you know what the side of a spine, like if you played Mortal Kombat, there's the spine that comes out and the finish him part of the thing, or I guess we can go with Halloween skeleton. There's a zig and a zag of the spine. And so as the zig and zag increases or decreases, sometimes if it's like that over time, then you get more load on certain regions of the spine. And so this is a representation of 4 different general types There's also, if you flip this person around forward, you'll see that there's like the scoliosis type. By the way, scoliosis is not curved deformity forward and backwards. It's curved deformity side to side. And that also adapts over time too. But if you look at this line, just as in the last picture, the line that intersects the femur with compressive load, you can do the same thing here. There's a line drawn through the human from the eye, from the head to the hips to the feet. And that's generally, we can figure out where compressive forces may be a little bit more so. And so if you allow your body to be subjected to vertical load over time like that, then it will remodel and say, hey, I'm just trying to help you out because I'm a dynamic structure. I'm just like muscle. I remodel according to what you ask of me. And that can be favorable or unfavorable. If you're trying to decrease, if your goal is to decrease the amount of bone formation in a region because of degenerative joint disease or so on. And so how you allow your body to adapt over time is important. Like, no one wakes up with arthritis. It happens over time. It happens over years and years and years. And I want to say it was back in the 80s or 90s or something like that. I think it was 80s or 90s. They realized that with you can't really reverse the what happens to, you can't reverse arthritis, but I think the thought is that you can prevent it from happening, or you prevent the progression possibly. The idea was based upon girls with knee problems with ACL tears. And so they found that within those joints, within those knees, the people who had the ACL tears generally had more arthritic findings over time. Like within 5 years, they had arthritic findings, degenerative joint disease in that case, over those 5 years. So it was how your body loads that region. Trauma or past injury is something that which may make you load differently over time. And so a lot of times that's why rehabilitation is required. It's to get your body to load better so you don't have things like this pop up over time. In this slide, I wrote down posture matters over time. And this one was an interesting one. I just pulled this study right before we did the presentation here. And it references down on the right side. And so this is an MRI. This is a flexion extension MRI, and this is regarding disc movement. And so the common thought is that if you round your back forward, the disc will move back in towards this disc herniations and protrusions will move back towards the spinal cord and maybe create a little pressure on it and create symptoms. In this case, you see that the extension actually increased the disc material moving back into the spinal cord region, creating some cord compression. In this case, it said spinal flexion had 3.3 millimeters of movement into the spinal column. And in extension, it had 8.9. I would imagine that would be part of the annulus of the disc, not the disc nuclear material, which is common too. And so everybody's spine moves a little bit different. Their symptoms are a little bit different. And what your problem or your pain generator is might be a little bit different than everybody else's too. And so posture does matter in this case because your spine, just like the bone, moves, okay? Or actually is dynamic, it moves around. Now, I'm going to cover Yana's lower cross syndrome. If you guys haven't read anything about it, I did do a write-up in my book, which I'll link in, I'll put in the link description. Actually, there might be a card that comes up on the side here, but if you guys listen to the podcast, then you just go in your podcast player links. But Yana's lower cross syndrome is, I think, a really good it's a good ideal theoretical model. And actually, it's a pretty good observational too. Like, this is a lot of times what we see with people. People on the left with tightness, chronic tightness of the erector spinae, iliopsoas, and rectus femoris. Those are called tonic muscles, which I'll cover in a second. Generally have more compressive in the, aspects in the backside of the spine. It's usually these people don't have really good movement patterns. Okay, they can move without pain most of the time, but a lot of times these people have an anterior tilt to the pelvis. Their booty will be sticking out. You'll see that there'll be like a big gully in the middle of their back between their back muscles that look really tight most of the time. It almost looks like you can put a carrot between their lower back muscles. And then the person on the right is the opposite. It's a posterior tilt. And so there's the rectus abdominis, the external oblique are helping out with the matter, the glute max in the hamstring, and so on. And so neither one of these positions is like the one you should stay in or be in. But when all these muscles work together, they create what we call co-contraction. It helps out to create decompressive efforts of the spine. It helps spare your spine from abnormal loading strategies. Now, the tonic phasic muscles, if you go in and look up Yanda's muscular imbalance syndromes, you're going to find upper cross and lower cross. I think these are really good starting points for understanding of not only that your diagnosis, your disc degeneration, your disc herniation, your your pinched nerve and so on aren't the only problem. Like, this gives a better idea, a better understanding of why those things keep maybe popping up. And so these are areas of the body or muscles of the body that tend to dominate movement because they have better energy systems. So tonic muscle groups are the ones that are typically facilitated in this picture. Facilitated, at least in the lower cross syndrome, it says rectus femoris and iliopsoas on the front side. And on the back side, the muscles that are facilitated or pretty hyperactive are the thoracolumbar extensor group. So like maybe even the QL would be in there too. The muscles that are a little bit dormant would be abdominals, glute medius, glute minimus, maximus, and medius. So all the glutes. And so there's other muscles in this scenario as well. But generally speaking, a lot of times people will go in because their back hurts and they notice that their low back muscles are tight and their rectus femoris and iliopsoas or hip flexors are tight. And then if they went to a trainer or a strength coach, that you'd see, well, the abdominals and glute muscles are kind of weak or inhibited in this case. And so the muscles aren't really doing their job. They're not really helping each other. They're not creating co-contraction and making a good ecosystem for the spine to survive. Over time, if you allow this to occur, in theory, abnormal loading strategies happen, and then you end up having adaptation of the bone, which creates degenerative disc disease. Now, if you look up in the upper cross syndrome, the facilitated muscles are the sternocleidomastoid and the pecs, the upper trap and levator. I mean, how many times do you guys go to massage therapists and they're like, oh yeah, your upper trap and levator are the tightest that I've ever seen. Right? Nobody ever says in the other group or category, the inhibited ones, the deep neck flexors, your deep neck flexors are the tightest that I've ever seen. No, because they're usually dormant. They're just not working well. Lower trap, serratus anterior is also in that category. And does anyone ever go to a therapist or a clinic and say, and they get told their abdominals or glute max are way too strong? They're way too active. It's not super common. And so my point is that the energy systems of these muscles are different. And so the ones that are facilitated, the tonic group, the ones that are helping, tend to help out longer. And then over time, they will create abnormal loading strategies. Now, here's a picture of DNS, open scissor. DNS is dynamic neuromuscular stabilization. This one ties into that same one with the Yanda's lower cross, upper cross type of syndrome. It's just a different strategy, a different painting picture, if you will. And so in this one, it describes a little bit more about how diaphragmatic breathing and internal pressure within the abdominal cavity matters in keeping you in an optimal position to have better load sharing amongst the spine and other parts of the body too. If you look at the picture on the left, you have the diaphragm and the thoracic and pelvic diaphragm or the pelvic floor, generally horizontal to each other. And you can see that everything is, it looks like it's a more compressive system. It's like a Coke can with a horizontal top and horizontal bottom. You look at the other picture and it's like a can that's kind of been tilted at the top and tilted in the bottom, like an open pair of scissors. What the theory is this abnormal loading strategy creates a scenario where there's poor internal pressure within the cavity. If you want to look this up, you can, or just trust me. Better intra-abdominal pressure helps to decompress the spine and helps support it. It helps support the spine. It also helps out to improve glute function, and it helps, or glute activity. It also helps to facilitate more abdominal wall, activity, which was what we went backwards into the tonic phasic group. It's what the ones that needed some help. That's why a lot of times rehabilitation of a hip or a back or a knee starts at the core. It's not a 6-pack or 8-pack or 12-pack. It just can the core function. I've seen people who are overweight have a perfectly functioning core. Okay, it has nothing to do with aesthetics. But as you can see in the picture on the right, it says the spine is extended, the pelvic is tilted forward, like they're taking an Instagram picture. The diaphragm is oblique. There's a suboptimal distribution of pressure, and then there's incoordination of stabilizer groups of muscles, and then there's more compressive overloading of the lumbar disc and joints. Okay. Now here's a picture that shows, this one's actually pretty common that we find mainly with squatting patterns. I do see it with deadlifting patterns too. These are pictures of the same person doing a deadlift, but two very different low back strategies or stabilizing strategies. The person on the left, the bar is still in generally the same position. The logo of the shirt looks really good. It looks up, so it looks like they are not dumping at the low back. They're not rounding at the low back, but they're extending at the low back. You can see that there's a dramatic arch. It's like a sway back. And this is something that may load the back side of the spine more than the front. And it's just inadequate load sharing. They're an open scissors presentation, more compressive load on the spine. The person on the right, although they look like they may not be paying much attention, this person is paying more attention to a bracing strategy or a pressurizing strategy than the person on the left. And so over the short term, the person on the left can get away with this. Okay, this works for a very long time. The person on the right, I think they'll succeed better over time. And if the goal is to lift weights, I think, or lift heavy weights, the person on the right is going to even do better. Okay, but posture with lifting really does matter. We see it a lot with squatting. People who have actually hip pain with squatting or low back pain with squatting, they tend to have a strategy where they're really extended on the left. It's almost like they're scared to actually look over the cliff or allow their chest to go a little bit forward, because you got to have a forward backward displacement. Like you got to allow the chest to go a little bit forward, unless you have a counterbalance like a goblet squat. But as they extend their back more, their back hurts more. And so essentially they're using their back as a hinge point versus their hips as a hinge point. Correct me if I'm wrong, but a deadlift is a hip hinge. You're supposed to get the drive from the hip, not the spine. And so that's why the spine's going to take more load over time, and at some point it may develop degenerative disc disease or other types of disc problems. Now, this is a great picture how posture matters with sitting. So there's lifting and sitting, and those are the two most common ones for people. Obviously, there's sport, but that's there's various different sports. With sitting, though, this is a picture of a cogwheel type of scenario. And if you can see the guy on the left, the cogwheels really aren't in alignment. Cogwheel guy on the right shows that he mainly just corrected his lower cog, and the rest of the cogs fell in line with it. And so normally, so if you guys are sitting there right now, like a really better strategy for sitting is not to raise your chest as grandmother told you to do, because that'll essentially make you like the girl on the left with lifting. She's just she's bringing her chest up. Tall chest, proud chest, if you will, which is really not a great cue for lifting. Person on the right here with sitting is not doing a proud chest cue because they're not shoving their ribs into the person in front of them. They're just dialing the pelvis forward. So you can grab your pelvis, dial it forward, dial it backwards as if you're like you have a clock dial. You're dialing it forward and backwards, and just find the middle. It doesn't have to be at either extreme. It's going to be in the middle that feels better to you. And so sitting with posture with better posture over time does matter. But if you have neurotically better posture, it's not going to help you either. Okay. Because it's really hard to find a better pressure strategy from within if you're extended all the time. Actually, when we teach a performance place, it's actually easier to teach while the person's in neutral or even rounding, like the guy on the left with bad posture. And similarly, we actually do have some people into their 70s where they actually, for quote unquote, their better posture, it hurts their body more. Like their back hurts more to have better posture. And if you see people walk around with walkers, like rounding their back feels better. They've been doing it probably for a very long time, and their body adapted over time to create bony formation, and now there's just obstructions. There's movement obstructions. Okay. Treatment. I think there's a few categories of treatment or parts of treatment which are important. The specific type of treatment, I can talk about those a little bit in turn here in a moment, but generally speaking, there should be some assessment to figure out what to do first. Assessment to figure out what areas of the body may be contributing to the excessive load on the spine in the first place. An example would be if you had a hip replacement or you had a hip injury and you never really recovered from it, it seems like it's never been the same. At some point, that load that's been taken away, the work that's been taken away from your hip will go somewhere. It's going to go to your knee or your back. It's going to go to a neighboring joint somewhere, or even the opposite hip. Work. It's like was it Newton's laws that you can't. I'm trying to think of one that would relate to this really well, but generally speaking, you can't create or destroy energy, right? It's going to go somewhere, or matter. You can't just create or destroy matter. But I remember the pool ball analogy. You hit one ball and another ball, and then one slows and the other one takes the extra energy. The same thing happens here. Load is the same. So you need to make sure your other areas of the body are working well to spare the area from progressing further with degenerative disc disease. Now, assessment of movement is important. You can even do these virtually. I'm sure you guys have seen a lot of our videos where you see us moving because you're watching us move. Essentially, doing things on video and watching people, you can see what movement looks like. I mean, we've all watched movies and TV and we see people move. We see people do things. You can see facial expressions and so on. So there's a lot of things you can pick up on video or having a trained eye look at you. Again, in person, they can put their hands on you, but it's not always needed. A lot of things that we actually do as movement providers comes down to not only talking to you, watching you, but then also doing some assessment to confirm what we found. A lot of times doing a treatment like an exercise or a stretch or watching you do other things that were suggested is helpful because if we pick the right thing, you generally can do it. If we pick the wrong thing, then you feel worse. And that's a confirming test to see that maybe we picked the wrong. We need to go back and observe the movements a little bit more. Also, assessments of habits is important. If you sit very poorly or you sit very neurotically, or if you lift as the person on the left did, as we mentioned before, then you may have load over time. And so we can give you as much tissue work and adjusting and mobilizing and medication that we want to, but if you don't change your habits, this is going to probably continue. All right. So we have a few things there. How do you move? What are your habits? And what are areas of the body that may be contributing to your back as well? Another part is assessing chronic programming or sport. All right. Some people, it's interesting. You talk to them a little bit more and you learn what's going on with their life. And you say, well, what do you do for fun? Well, I like to hit my head against the wall. And you're here for headaches? Yeah. Yeah. Why? It's like, well, part of your daily ritual is hitting your head against the wall, Now that might seem ridiculous to say, but, people who have back pain may be doing things chronically in their day-to-day program, weight training, or sport that triggers their problem. And they have no idea they're doing it. They have no idea that it has a part into it. And we don't have to necessarily take that activity away. Like we don't have to take a back squat completely away, but you may decide to coach it differently, or you may decide to give them a different version of a squat to make it so the body feels better. And then you go back to the back squat later and then build it up from there. You don't have to take it out forever, but essentially you as the client are in complete control. Okay. I always tell people all this time. I remember there was I watched a show called Better Call Saul, and I thought it was a really good scenario. If you guys have seen it, basically the attorney gave the banker advice. The banker kept ignoring the advice. And finally the banker said, well, I don't know if I want to work with you guys because, things aren't going well. And the attorney came back and said, look, my job is to advise you. You can do whatever you want, but I'm advising you. We advised you to not do that. So you decide what to do. And so you guys are all under your own control. But you may need advice. If you need advice, you need to seek someone with education and experience working with something like this. Ideally, you need to restore human movement as well. You need to restore the movement. If you have lost hip rotation and you need hip rotation to spare the spine, but you can get it back, then you need to do so. If you can't get it back because you have arthritis in the hip where it's been replaced or so on, then that's a whole different story. But if you can get it back, you need to get it back. And sometimes that requires you to go to somebody for some help. Also, you may need to increase function where you need it too. Say you had a hip replacement and the hip has full range of motion and it just never fully trusted again. It hasn't worked really well, but it's theoretically it's good. You need to restore function. And that's going to require you to do some corrective exercises or some patterning exercises under the supervision of somebody typically. Now, this picture here is this is one that describes a little bit more of like the process that people go through sometimes and what choices they take really does matter based upon their overall like how they fare with an injury. And so we see in the middle here people have an injury and they have an experience with pain. How they decide to work with it from there is totally up to them. Some people will have back pain and decide, I'm never doing that ever again. And in that case, next time back squatting comes up, they're like, I don't want to do that. And they become fearful of the movement. And then if they do it again, they become really scared about what may happen if they do it, or they just avoid the thing completely. And eventually, one day, they may become disabled and depressed, and the body it's not as strong anymore. But eventually, they're going to have to help someone move. And then they pick up a couch for them, and then they have pain, and then they worry about it, and so on. And what feeds further to the cycle is essentially bad information. Your back is a bad back. It'll never be the same again. Never lift over 20 pounds ever again. You're going to need surgery one day. It's a matter of time. Just come back when you're ready. Most of this is just complete BS. Some of it may have some truth to it. Obviously, lifting a certain amount for, some people at a period of time in their life is completely appropriate. But the way things are said is really important. I'm sure many of you probably can recall something. If you like back in high school, you remember a moment with your coach where it's like, this should have been forgotten years ago, but it's not. I remember one time that I tried to extend a single into a double, and at that moment I got thrown out at second, and we ended the game, and the coach came out and just reamed me on the bases, and I haven't forgot that. There's a lot of other things that I completely forgot, situation games I never remember any again. I know one lady who was told by a physical therapist that she worked with that her ankle was the weakest ankle that she's ever seen before. And she should never play soccer again. To this day, this is 15 years ago, this girl is so afraid of using her ankle. She literally has nightmares about turning her ankle. It's her biggest fear. So installing fear in people and bad information is it's a bad thing. Now, the way this can be navigated by a healthcare professional to have better verbiage is like, your ankle seems like it needs some stabilization. Don't worry, you can work with that. If you decide to play soccer right now, you might have a little bit of mishap and turn it, but don't worry, we can settle that down if it does happen, which is the truth. Like the last thing you want to do is say, you're the worst person I've ever met in life. You're ugly, and essentially that's kind of what we're doing, but to their other parts of their body. Now, the other scenario that it could take is the person has injury, they have an experience with pain, and then they get helped out of the pain. They have less fear of movement. They're basically they're confronting their problems and they recover. Seems like a way easier way to go. And that's typically what happens when you're under the guidance of somebody who can help you. Okay. You need someone to be on your side. This happens. We see this a lot with people that with reoccurring injuries or different things that come up. I remember I had someone recently that they got hurt while deadlifting, and we were talking about it a little bit because their back had recently recovered really well. And they said, well, I got hurt, but I'm really glad this happened now, because I feel like if it didn't happen with you, or if it didn't happen with you, then it was going to happen at some point anyways, and I would deal with it poorly then. And I said, that's a really great way of looking at it. Like normal things under normal circumstances don't hurt. So I'm not going to say that your body's broken or anything. It's not tolerant of that movement at the moment. Let's scale that back a little bit, and then we're going to reintroduce it again in a little bit. And so that's confronting it at some point, and your body will thank you for that over time. Now, there is, I missed one of the slides here, but back into those muscles that work a lot, the tonic phasic groups. I've had people ask me recently, like, why do those ones always work so much? And so one thought is that we call the lower irritability threshold. So in this picture, I put a Jeep on there that is rock crawling. I've seen people do this that don't have lockers on their cars, and you see one wheel spin, and the other wheels don't really spin. They're just not moving because the other wheel that's spinning a lot is taking up all the juice. And so hypertonic muscles disrupt force coupling and normal joint mechanics in a few ways, but the first is via the lower irritability threshold, meaning they don't really require much electrical impulse to contract, aka the tire spins. So something like, say you're doing a back squat when you really want to work your legs, but the only thing that works is your back, then usually those muscles have a lower irritability threshold. So there's a few ways to address this, but that's probably the easiest thought process with it. A couple exercises that I'll show you a few that I like here in a few moments, and I'll take this mic off, and then we'll let the podcast people go. Is we're going to cover two of these: side planks, squats, lunges, walking, and pull-ups. I'm not going to do pull-ups today, but I thought I'd put that in because you got to question the idea of why. Why would a pull-up help degenerative disc disease? Well, it's because the body works as one big unit. You ever see someone doing pull-ups and they just hyperextend their back when they're pulling up? That's because their abdominal wall may be inhibited. We went back into that lower cross syndrome. The abdominal wall is inhibited. And so essentially they're compressing their spine when they're pulling up, because the rest of their body's not helping. Now, you can use the pull-up as a really great corrective exercise, because you can challenge them to only pull up as long as essentially we slap them in the stomach. Don't let me slap you. Stiffen up so I can't slap and hurt you. And so that's the only goal that matters. The pull-up itself really doesn't matter too much. It's can they keep stiff and then pull up as well. Okay. Some prevention that you guys may or may not be familiar with is number one is movement snacks. I consider these prevention because although movement snacks can be really helpful for people who are having pain too, it may be too general to actually solve the problem or the pain that they're in. Movement snacks is simple. You snack throughout the day with certain chips and stuff that you like. Same thing with movement. Just get up and do some movement snacks. And that might be lunging, walking more, crawling on the ground, changing postures, just something different. Snack throughout the day. It may help you. The second thing is exposing yourself to relative heaviness. I used to call this strength, but now I'm calling it relative heaviness, mainly because your body doesn't necessarily always need to be strong, I don't think. I think it just needs to be exposed to a challenge. As I mentioned before, that person who is avoiding back squats, at some point they help someone move a couch and they hurt themselves. The thought is that they're just generally unprepared. So exposing your body to some relative heaviness periodically would help you. So at any point in time, your body has been prepared to encounter the task that it may be asked to do, such as helping someone with a couch. I was asked to just earlier bring a dresser out of my dad's truck. I didn't know it was going to be that big, but I'm really thankful that I've exposed myself to some heaviness over the last few months to where my body is now ready for it. It's a preparedness issue. The third thing is picking up a few physical activities. These shouldn't be really heavy, but it should be more of just like generally being physically active. Running, sprinting, jumping, hanging, hitting, something like that. Pickleball is a good choice. I prefer baseball and sprinting. Those are just my things that I like. But it doesn't have to be cardiovascular fitness. It can literally be as silly as chasing squirrels and chasing dogs. The fourth thing is prevention is you want to have an assessment of chronic programming in sport, like I mentioned earlier. Sometimes the best prevention is just filling a void. If you don't do hip hinging movements in your program because you were scared of it years ago, perhaps you add it, and that may just help you condition your hip to hinge better, which will spare your spine in the future. Now, these are a few excerpts from my book. I will put a link in the description for those of you people up. Actually, for the people doing the YouTube, you may find a link that comes up on the side. But pain's not here to punish you. Pain's here to protect you. Just like when you touch a hot pan, pain tells you that you're doing something's not right for your body. For this reason, paying attention to what your pain can be, man, I wrote this and I'm having trouble reading it right now. Paying attention to your pain can be an asset as you work on recovery. What makes your pain increase or decrease? What positions do you have no pain in? What positions do you have a lot of pain in? Can you use pain to find control over your situation? Pain truly can be an asset to your recovery if you allow it to be. This is why numbing pain with medication, ice, and heat can slow your process because it removes your body's alarm system. Next is we have the I call this the MAP-A-Load framework. This is something I developed. It's based upon a few strategies I've used over the years, but I thought the acronym would work really well. And so M means modification of pain, A means activate the support system of the body, P means patterning movement, and A is applying load or relative heaviness when ready. And so this is something we cover in that book a little bit, as well as some of the other books, but this is generally how we program at Performance Place for various different types of problems, such as degenerative disc disease, to help out. And so modifying pain is a really, really simple way to make it so your body can move well and you can sleep well and recover, but it does not create any adaptation in regards to changing how you move. It doesn't facilitate muscles that are off or dormant, and it doesn't deactivate muscles that are hyperactive. It doesn't change low irritability threshold. It just makes you feel more comfortable. And so activating the support system, patterning movement, and adding load are really the ways to go about with that. So now I'm going to go into a couple exercises I thought I'd share with degenerative disc disease. And these are the favorite ones that I have that really reduce pain really well. For that, I'm going to switch over actually into the headphones here. And so if you guys pause for a moment, we're going to do that. And for all you on the podcast, I want you to subscribe to the podcast and listen to the next one. But also go to the YouTube channel, check this stuff out. All right, everyone, just pause here and we will actually get into the exercises here. Okay, now we're on the AirPods. So one of the best ones I think to do is it's called 90-90 breathing. I have a wall here that's really helpful to get the legs in a good position to do to find the position that works best for you. And so it's just going to be just here, like so. All right. In this position, I would just lay down and relax. Place your hands on your belly and breathe into your fingers right about here. I'm going to move my leg just so you can see relative position right here, but we're going to hang out here and just chill. You may notice just by being here for like 30 seconds that your pain already feels better. Some of you will experience some sensitivity of the spine just because of where you're at. I wouldn't do it on hardwood floors. You're going to do something like carpet like I am right here. Generally, if you hang in this position, things tend to desensitize pretty well for people truly with degenerative disc disease, arthritic findings, and so on. If this is something like a flexion intolerant back, like discogenic symptoms, and you're 13 or 20 years old, like this probably isn't going to work for you. But the more subsequent problems you have with your back, which it typically comes back a little bit, it's just you can obviously manage it well. I had someone just this week that they were 13 years old when they had their first issue with back pain, and now they're 30 years old. This would have not helped them when they were 13 after questioning them, but it helped them today, and that's fine. So this is position one. This is just the recovery position, as we say. If you want to make it harder, you can go into this position and bring your feet up off the wall and continue to breathe into your fingers. And then take a break on the wall like so. And so that's the easiest thing at the moment to do for most people. Normally for the rescue position, I have people do it for about 10 minutes a day.
You can also put your heels on the bed or on a chair. For the actual position where they're doing the effort, I tell them to just go until they feel like their belly's a little tired. I kind of want them to feel the belly challenge. If you feel it in your back or your hip flexors or your groins or your hamstrings, that's not ideal. And normally that requires more specific coaching to find something that's going to work better for you. But essentially what's happening there is your tonic group is taking over. And so we need to make it so the phasic group, the abdominal wall, is actually doing the work. And so in that scenario, it would be a really bad one. Now, another easy one to do, this is called child's pose. I'm going to bring the computer down just so you can see like a better view on this. A child's pose, or actually, you know what? We're going to do a cat cow. A cat cow, I think, be a more unique one based upon what the last one was a bit more of a positional. This one's going to be more of a movement. Okay. Now, we did a video on this on YouTube recently where me and Don went over like cat cow and how cat cow is good and bad for certain people. And mainly because some people just plow through any pain when really you would mainly touch and go on any problems at all. And so when you go up here, if you feel pain, just don't go through it. If you go down here, if you have pain, just don't go through it. You're just going to stay in the range that's not painful. Okay. And when I'm doing this, I'm thinking about like I got a tail here. I'm trying to move my tail down and I'm trying to move my tail up. And that helps address like the lower segments of the lumbar spine, the low back, like L5, S1, L4 type of area. Okay. But also because you're focusing from the lower half here, it doesn't make people feel like they're doing this proud posture thing. The proud posture thing can create a lot of compression into this region. And as I'm feeling just my back right now, I can feel like I can fit probably a carrot between those muscles right there. And so I kind of want to do it to the effect of creating some pressure and being able to breathe in those points of the fingers as I'm going through the movement. If someone were to take a look at you, they should not see like big rails of muscles in your low back. They should see that it looks like generally like that person on the right side in the lifting picture that we did. So those are two of, I think, the best exercises for people who are dealing with a degenerative disc disease, at least pain. Number one, the first one, the one on the wall, addresses M, modification of pain. And then also the second one is a little bit more of activation of the support systems, kind of venturing into different purposes. And that's why in this, in the methodology that I'm talking about of the map-a-load framework, I'm talking about, there's a methodology, a method to the madness where you're trying to get someone out of doing just modifying pain activities. If you only modify pain, this will continue to come back. You'll be doing it daily for months to years or to the end of your life, just making it so you feel better while the rest of the day your body gets worn upon by gravity, and then it starts to act up a little bit. Now, there is obviously a way out. I don't want you to think that this is going to be something that you're going to have forever. Most people, you're not going to do anything to change the actually degenerative findings in the spine. Your X-ray and MRI will look exactly the same, and that's okay. But if you activate the support systems, getting the phasic muscle groups to help, that will help decrease the irritability threshold of the tonic group muscles. It'll hopefully get you out of the tonic phasic cycle of lower cross syndrome, and then your spine will potentially get more intra-abdominal pressure, which was breathing into the fingers, and then you can move it into more loaded exercises, like in this case is a deadlift, but you don't need to deadlift. Not everyone needs to deadlift to feel better. By the way, I should probably note that all those things that people put out on deadlifting is the worst exercise for your back. I think it's completely inaccurate. It's how you do a movement and how responsible you are with it that really matters. I know a lot of people who deadlift on day one with their degenerative disc disease, and they feel much better from that. And so it really comes down to strategic programming to figure out what to do. If you guys are looking for more information on stuff, we do have assets and learning resources on our website. I have some of the links in the description below, but there's also a webinar that me and Don did on low back, sciatica, and so on, which I think is really helpful, and it's probably more fun than this one. We like to mess around on camera and make it educational for you guys. But at any point, if you guys want to work with us, we can certainly work with you. We're in Costa Mesa, California, and we do virtuals as well. So we love doing this. We love working with people with degenerative disc disease and back pain, disc herniations. It's all good fun. And so I think we're pretty good at it, and we're very honest about if we can help you or not. So looking forward to working with you. Subscribe to the YouTube channel. We'll see you guys next time.